Well, I know this is a little bit of a mixed audience. I'm going to just start by running through a few basic facts about organ transplantation that all the physicians and all the medical people here are undoubtedly very well familiar with, so I'll go through those fairly quickly and then go on to the ethical issues. The ethical issues I'm going to talk about are not all of the ethical issues in organ transplantation by any means, because that's not possible to do in a 10-hour talk, much less the time I've got allotted. And actually, one set of ethical issues that are very interesting are particularly relevant here at the University of Louisville, but I'm not going to be discussing, have to do with doing organ transplants sort of at the frontier, where it's really innovative surgery. And in fact, I'm one of the editors of the American Journal of Bioethics, and we published a very nice target article and a whole set of commentary articles on face transplants and whether the field was ready for a face transplant and what it would take to really ethically do that. And that was actually published by a group here at the University of Louisville. It's a very nice piece. So, and we were very pleased to have the opportunity to publish that. So thanks for publishing it with us. So I'm not going to talk about any of those issues. I'm going to really talk about the ethical issues that arise in the more routine sorts of transplants: heart, lung, liver, kidney, that sort of thing. Just some basic facts. As of Monday or Sunday, the 4th, there were, when I checked at 5:42 Eastern Standard Time, there were just over 95,000 people in the U.S. on the wait list awaiting an organ. From January through October of last year, there were a bit over 24,000 transplants performed and about a little over 12,000 donors. So we're on pace to what would have been expected all year long watching the data to be somewhere in the ballpark of 30,000 transplants. Given 95,000 people on the wait list, 30,000 transplants performed, you can imagine what the situation is, which is the number of people on the wait list continues to grow year by year by year. It was 84,000 just, I think, 3 years ago, then 87,000, then 90. We're up to 95. I anticipate us breaking the 100,000 barrier in the very near future. Most people on the wait list are waiting for kidneys, though there are a significant number of people waiting for livers, smaller percentage of heart and lungs. The vast majority of those people on the wait list are adults. Only about 2,000 on the wait list are children. Just some average wait times, some data. It's actually quite variable. And this is, again, people waiting for cadaveric organs, not taking into account directed donation. But there's a significant number who get organs in a fairly short period of time. 21% get under 6 months to a year, though there are a number who get who it takes over 5 years on the wait list to get an organ. And this is not equally distributed, and I'll be talking about that as an issue. And you see similar discrepancies in wait times for liver, again, over 25% waiting over 5 years, and for heart, 26% waiting over 5 years on the wait list. Over 7,000 patients die every year on the wait list, and even for those who are not dying, especially for kidney, which make up the bulk of the people on the waiting list, there are significant quality of life issues for patients who are on dialysis. The basic organ transplant system that we have in this country was set up by the National Organ Transplant Act in 1984. It established the Organ Procurement and Transplant Network, OPTN, which is under contract to the United Network of Organ Sharing. UNOS, which manages the OPTN. The U.S. is divided up into a number of regions, and within each region are service areas that are operated by local organ procurement organizations. And the local organ procurement organizations really are, in a lot of ways, the real site for a lot of the action in terms of organ transplantation. I'm assuming Kentucky has just one OPO, is that correct? Right. So California, in contrast, we have 4 OPOs. And you may not be as aware of it because you only have one OPO in Kentucky, but this is not like the House of Representatives where you have more or less proportional division. In California, we have 4 OPOs, one for the San Diego area, one for the Los Angeles area, much larger than the San Diego one for the Bay Area, also large with millions of people and a lot of transplant centers, and one essentially for the Sacramento area. Right? So you've got one really tiny OPO and a couple of huge OPOs, and that actually winds up making a very big difference. The thinking originally was that it really didn't matter that much how proportional it was, because if you have more people, you have more organs to donate, if you have as well as more people who need them. But the idea that would be evenly distributed turned out to be false, and that's a cause of some real problems in terms of justice that I'm going to be talking about. In the U.S., there are 259 transplant centers operating 923 individual organ-specific transplant programs. Basically, the donation and procurement process in the U.S. is run by the local OPOs. And for the most part, those are patients who meet whole brain death criteria. So you can imagine why it's so hard to get organs, because you have to meet just this very narrow set of circumstances of being brain dead, but having the body essentially still actively perfusing organs. The listing decisions of who gets listed, in contrast, is made by the local transplant program. So who gets listed is up to the individual program. UNOS has a system of distribution of organs, with the exception of the directed donation. The transplantation and follow-up is done by the local program. Oversight and monitoring are done by UNOS and CMS. How do local listing decisions get made? Basically, it's really depends on the individual program. That's where there's a lot of sort of flexibility in the program, for good and for bad. There's a medical evaluation in which you have to make an assessment about likely graft survival, what's the prognosis, how much benefit is a patient likely to receive from a transplant. There's a psychosocial evaluation to determine the likelihood that patients will be adherent with their very rigorous medical regimen that's required for transplant to be successful. And there's also something sometimes referred to as the wallet biopsy and a financial evaluation. Most states and most programs actually do a pretty good job of getting most people eligible for organs, but there is some variation there. And I know we had a case in actually at our hospital recently where a child in California, we cover heart transplants for kids, but in a neighboring state they do not. And we had a case where a child from that state was there, didn't have adequate insurance, and if you don't have $1 million guaranteed one way or another, you're really not eligible for a heart transplant. Now, once you're on the list, that's the determination of who gets on the list. Once you're on the list, your place on the list is determined more or less objectively by a number of factors, like how sick the patient is or how long the patient has been on the wait list, depending on the organ system. And there are very detailed criteria that are developed in a uniform way for each of those things. Medical compatibility, obviously, is going to be a major factor. And then geographical location. So organs are typically distributed first within an OPO area. So here are the ethical issues. That's just to give you a flavor of the system. Here are the ethical issues I'm going to talk about. There are a whole lot of justice issues, including issues about listing, distribution, solicitation, and a new thing that we're seeing more and more of, at least out in California. I'm not sure if you guys are experiencing this, but transplant tourism. I'm going to talk a little bit about donation after cardiac death. Do you guys do DCDs here? Okay, so I'm going to talk a little bit about that. That's because that's a very controversial thing that's happening more and more. JCAHO now, as of January 1st, expected every hospital to have a policy in that regard. And one of the things that's been surprising is how many places are really opposed to DCD. And I'll talk a little bit about the ethical issues there. And then finally, some ethical issues in management. I'm not sure how much of this news has reached you, but we've had a whole series of scandals around some of our transplant programs in California. We had a problem with our Kaiser kidney program. There were several problems in Southern California at St. Vincent's Hospital and at UC Irvine. And I'll talk a little bit about what went wrong there and what we might learn from it. So first of all, justice and listing decisions. One question that you have to ask is whether or not values influence who gets listed. And in fact, Sheldon Zink, who David and I both knew at University of Pennsylvania, is an anthropologist who did her dissertation sitting in on cardiac transplant listing decisions, and she absolutely found that there were ways in which the decisions were being shaped by the values of the individual practitioners for deciding who would and who would not get listed. And it's very hard to list those, to keep those things out when you're making certain kinds of judgments. Another big question that arises when you're thinking about these patients: should we list neurologically and cognitively impaired children or adults? Should you list patients who have Down syndrome? Should you list patients who are in a persistent vegetative state? Where do you draw the line between those kinds of patients? And under what circumstances and how should those things take place? Should we list people from other countries? Right now, the system does allow a limited number of transplants to go to people from other countries. That can be financially rewarding for institutions because they typically charge higher rates than you get from insurance. But the current system allows just a very limited amount of that. And basically, in thinking about a lot of these things, we often see a trade-off between our obligation to be good stewards of a very scarce resource. And it's not just a scarce resource. It's a scarce resource that's unusual in that every time an organ goes to one person, a cadaveric organ goes to one person, there's other concrete individuals who are not getting that. And that really makes it in some ways more of a triage situation than just an allocation problem. And how do we weigh that stewardship obligation against our obligations to meet the rights of each individual? So adherence becomes a big category when you think about listing. It becomes an opportunity or a way for values to actually play themselves out. Oh, this person's going to be a problem. They're not going to take their meds. They've lied to me. I don't like this kid, so we're not going to list him. And in fact, there are also just empirical facts that if you're socially and economically disadvantaged, it actually is more likely that there are going to be factors that are going to be problems for adherence. If you live 3 or 4 hours away from the nearest transplant center and don't have a car and don't have any way to make your medical appointments on a regular basis, there's going to be a real likelihood that you're not going to be adherent with those strict requirements, and nobody wants to see something as valuable as, say, a heart go to waste because of adherence problems. One of the big problems in this area is that we don't have data for many of the factors that are actually often cited for exclusionary criteria. So, for example, some programs will, if you have smoked tobacco in the last 6 months, there are programs that may not list you, and they say, okay, you have to quit smoking, and that'll prove to us that you can be adherent. There are other programs that don't take that into account, and there's no data about the extent to which that really is a predictor of adherence. There are better data about alcohol. If you've got a history of alcoholism, there's pretty good data about recidivism for that, but it's very hard to know how to sort out some of these different causal factors, and we probably need to do a better job with that. And then another question in this, what do we owe to uninsured patients, and how do we make decisions about them? And I think there's a real issue about making decisions for society as a whole and how we're going to distribute funds versus the bedside decision. That tough case that I mentioned before, there was no, they did not have, the family did not live in California. There was no money for a heart transplant. If we were going to spend $1 million of our hospital's resources taking care of that child, that would pretty much wipe out our resources for taking care of these kinds of patients who can't take care of themselves for a 2-year period. So you're weighing a heart for this kid versus all the other things we can do over a 2-year period. And that's actually at a larger level something that happens. The state of California does pay for pediatric heart transplants, but I know one county where we did a heart transplant that pretty much wiped out almost all of their social medical services for that county because it took up all the funds that they had for the year. What about exclusion of developmentally delayed? There are 2 different arguments that are given typically for why these patients ought to be excluded. First is that it's thought that they may be not able to take care of themselves, and so there's a straightforward adherence problem. But the other argument you sometimes hear is that there's just not as much benefit for those patients as for other patients. This is because the transplant in these cases typically will not improve whatever the underlying condition is that produces the developmental delay and restore full functioning. It may prolong life, but it won't necessarily restore full functioning, and therefore it's seen as not being sufficiently beneficial to justify. In addition, it's also important to remember that for these patients, as for any patient, there are long-term harms by virtue of the transplant. Our transplant teams like to say that when you get a transplant, you're trading in one disease for another disease. The acts of what it takes to actively manage being a transplant recipient is itself a kind of a harm, and it's thought that if there's not sufficient benefit because of these problems, that maybe this represents a kind of harm to these patients. In spite of these arguments, I think that there are reasons to be skeptical of these arguments. There's not much data really about adherence for cognitively impaired or mentally retarded patients, but what data does exist suggests that you actually can have pretty good outcomes. There was just a review article of the literature published in 2006 by Steve Reese's group at Ohio State. There are 6 centers that have published data on their experience with renal transplantation of patients with mental retardation. A total of 34 individuals were transplanted, and the 1-year survival rate of 100% and 3-year survival rate of 90% actually compares favorably with the expected statistics for those patients. Now, obviously, that's a relatively small number, so the data is not very robust. and we have little or no data for liver or heart. That should say heart. We have little or no data on liver and heart transplants because partly there's just so few cases where that's happened. But there's at least some information that suggests that the outcomes for these patients may be good. And if we're going to deny them on the grounds of adherence, it would seem to suggest that we ought to have evidence that adherence really is going to be a problem rather than just an assumption that it will be. In terms of the benefit argument, I think that argument makes a lot of sense in some ways for at least some of these patients. But where do you draw that line? And in fact, David Orntlicher has argued that denying life-prolonging transplant on the grounds that it doesn't constitute benefit may very well be a violation of the Americans with a Disability Act. So it may be illegal, even if at some cases it might make a little bit of sense. So one other question that you might ask is, does this happen? Do we in fact exclude these patients? The fact that there aren't very many of them is some indication that these patients are excluded. But there's actually a little bit of data on the adult side that's been collected. This is actually pretty old data. But back in '92, Levinson and Olbush did a pretty comprehensive study and found, looking at different programs, that a large number of transplant programs actually do consider developmental delay in their listing decisions. And it also matters to some extent by organ system. And you can see that for patients with an IQ of between 50 and 70, which is considered mildly impaired, it's actually for heart programs, a quarter of the time, that's an absolute counterindication. So they would never list somebody with an IQ between 50 and 70, and only 6% of the time for kidneys. So you can see a lot of difference there, although it does happen some. And liver in between, it's a relative contraindication, so it would be taken into account, but not necessarily automatically exclude patients, very high percentage of the time. And it's no contraindication at all, not taken into account, almost half the time by kidneys, but rarely for hearts. For patients who have moderate to severe deficits, and this sort of lumps together what are regarded as moderately impaired, which would be an IQ between 35 and 49, as well as those who are profoundly or severely cognitively impaired. You can see that for heart programs, it's an absolute contraindication. Almost 3/4 of the time, a quarter of the time for kidneys, about half the time for livers, and no contraindication at all, about a quarter of the time for kidneys and only 6.4% of the time for hearts. So it seems clear that at least in 1992 that these patients, and these were again mostly adults, were being excluded on this basis. We're in the process of putting together a survey for pediatric patients that meet these criteria, and we've already got, we've started off by surveying the 88 pediatric transplant programs that do the most transplants. They're in the upper half of transplants, and we got 50 responses out of 88. We're now in the process of expanding this to include all pediatric transplant programs, and we're also going to be going back through that initial group and try and build our numbers up. But in our initial data that we've collected, we found, just like the earlier Levinson and Olbush study, that it's all over the map, that about 43% of the programs' neurodevelopmental status is always or usually considered, 39% rarely or never used, and we found actually a very similar breakdown for organ systems to Levinson and Olbush. Heart programs are most likely to take it into account, kidney programs least likely, with liver programs in between. We also, in addition to asking them about their processes, we actually gave patients 2 scenarios, and this was in some ways for us the most surprising result. We gave one case that was a really tough case where we thought probably it would not be unreasonable for programs to grapple with and think that they maybe should take it into account. But we gave them one case that we described as our ADA violation case informally, which was a case with a patient, again, for each of those 3 programs, slight differences, but it was a situation where you had a fairly high-level functioning individual who was mentally retarded but able to go to school, fairly functional, likely good long-term outcomes. And we were surprised that in that particular case, while the vast majority of kidney programs would list that patient, even for that case, the vast majority of heart programs would not list a child, even for relatively moderate developmental delay. So obviously this is a big issue. So I got a Greenwald grant. We brought together a group of the leading pediatric ethics and transplant ethics people in the country to think about how we ought to grapple with these issues, given that we now know that these patients are being excluded. Should they, and if so, or if not, how do we draw lines? What policies should we have? What we wound up reaching consensus about was that mildly and moderately impaired children are entitled to the same consideration as other children, and parents should be allowed the choice of going forward for the transplant. It should never be an indication for patients solely on the basis of their cognitive status if they're only mild to moderately impaired. Severely and profoundly impaired children, that we could not get consensus about. We all agreed that if there are complications that are associated with reduced survival, that it would be reasonable to exclude on that basis. But for those patients, we couldn't reach any other agreement except on process. We thought all patients should be assessed. If the parents want a transplant, every child is worthy of at least get a developmental assessment. That assessment needs to be adequate, and given how important developmental delay is as an exclusion criteria, we were shocked to also find out in our survey that for most programs, it's actually done in a fairly ad hoc basis, that given a scale to describe fairly rigorous structured requirements to loose requirements, most aim towards loose requirements. So there needs to be adequate developmental assessment, and the developmental specialist should be part of the team. And we think that actually could make a big difference. We know for our liver team, that developmental specialist made a huge difference. Our kidney team saw how important that was and is now adding a developmental assessment as part of their team. And I think it really can make a big difference. And then finally, we did have consensus that for patients in a persistent vegetative state, it's just not an adequate use of resources, and there was consensus that it would not be appropriate to list those patients. Other issues, ethical issues in distribution. In the current system, you get listed at a transplant center within an OPO area, but it is possible, if you've got the financial resources, to be listed in multiple OPOs. If you've got the resources, you can pick and choose where you're going to be listed and actually be listed in a lot of different places at the same time. A lot of patients don't have that, so that financially, if you can afford to and you're a little bit aggressive, you can greatly increase your chances of getting an organ compared to people who don't have those funds. HLA matching for kidneys is used as an important criteria as part of the biological system, and this winds up meaning that certain groups, for example, African Americans, wind up on average waiting about twice as long for kidneys as Caucasians do, but actually there's growing body of evidence that such HLA matching actually doesn't have that big an impact on outcomes, and so it may be that there may be some room to do something to improve some of those outcomes for some of those populations. Another problem is the potential of the directed donation process. I'm going to keep going and have questions at the end. Directed donation abuses. The directed donation possibility means you can essentially opt out of the system, and nobody has ever done this. LifeSharers showed the way to make this happen. They essentially have a list of people who've all agreed to donate, and therefore they want them to get priority for organs, and they basically distribute their list, and that way when somebody is in a situation to donate cadaveric organs, they're supposed to basically direct their donation to whoever is on this group's list. What this shows, though, is that this could potentially be used by other groups. Supposing there's a group that says, we don't want to give our organs to people of different religious groups. I only want my organs to go to somebody who's a Catholic. A group could put together lists of Catholics, and you could have directed donation that will allow invidious discrimination in terms of the distribution of organs through this mechanism. Some people have said that maybe we should think about whether donors should be given priority as recipients in general, and should that be added in the weighting in some way. And the biggest problem maybe is geographical variation in wait times, which I've already alluded to. Geography winds up making a big difference because the large urban areas tend to have both a large number of patients who need organs and actually often lower giving rates because there's a lot of mistrust of the medical system in some of those subpopulations, although that's been getting better. But the result of this is that large urban centers with OPOs tend to have much longer wait times for organs than areas that have of different kinds of populations and are geographically smaller. So for example, in California, UC Davis, which is in the Sacramento OPO area, the patients who get livers there are much, much healthier than the patients in the Bay Area. And the wait time for kidneys in those two areas are literally a factor of 2. It takes twice as long to get a kidney in the Bay Area as an hour and a half away at UC Davis. And this is generally the way things are. In California, the LA and Bay Area OPO are two of the worst, along with New York, and it can make this much of a difference. In New York City, you go across the bridge to New Jersey, you're going to get a liver when you're much healthier than you will. So these things cross state boundaries. That makes a big difference. It depends on what part of the country you live in. It can be much better. And again, these distributions are not based on ischemic times. These boundaries are in some ways artificial boundaries that were created to correspond to some extent with where the major transplant centers were. Now, some states like New York have decided that this is such a problem that at least within those states, they're going to distribute organs to everybody equally within the whole state. So in New York, livers get distributed equally throughout the whole state. In California, I testified before the state legislature recently, and they're considering changing that for livers in California. But it's important to note that if we do that, if we distribute livers equally to the whole state, it likely would lead to the closure of the UC Davis program. So that's one of the trade-offs you're dealing with. A program like UC Davis only does about 30 liver transplants a year. You need to do at least 12 in order to have enough practice to stay licensed. But since their patients are almost all relatively healthy when they get livers, most of those livers would actually not be going there. They'd be going to the Bay Area or to Los Angeles, and their numbers may actually dip below 12, in which case they could no longer have a program, and it would mean all of their patients would have to travel to the Bay Area, an hour and a half away, in order to be able to get their care for their transplants. So that's one of the trade-offs. But it's clear that right now, on the whole, the distribution systems are geographically unequal, and it's a profound inequality in the system, one that UNOS has tried to correct, but there's been so much objection from programs like UC Davis, it's one that nobody's been able to really do much about. Let me talk about solicitation, because as I already mentioned, this is a way out of the program. The most obvious problem is cadaveric solicitation, and when you've got directed donation of cadaveric organs. In Texas, there was a famous case where somebody put out a full-page billboard ads basically saying he needed a liver, and then there wound up being news stories about this. And so somebody who'd seen those stories, their aunt died, they said they would be an organ donor, and they donated their liver, made a directed donation of this cadaveric liver to this patient who had made his appeal. This patient was, I'm not even sure if he was on the list, because he also had metastatic cancer. And in fact, he got his liver, and he died 2 or 3 years later as a result of complications due to his cancer. Obviously, this is a huge problem if we move in this direction. And for live donation, we're seeing this grow up more and more. Web solicitation, there's a for-profit website called matchdonors.com that essentially lets you put up your pictures of yourself, say who you are, and try and get people to come forward and be a live donor for you. And then there's a gradation from that to what about announcements in churches or in offices or people who post flyers. So there's all this gradation for the solicitation process. There are a lot of problems with the growth of this kind of system. If you look at live donation, it's been an interesting historical development from a period when Starzl and a lot of the other founders in the field thought it was a violation of prohibitions against doing harm to people for no benefit, and so shouldn't be done at all, to everybody saying, well, of course, for loved ones and our close family members, I may have no medical benefit by donating a kidney to my wife, but it's obviously of tremendous benefit to me in other ways, and so it seems reasonable. And there's just been a slow expansion from initially just very close immediate family to more distant family to friends, very, very close friends. Our renal team talks about the bass fishing rule. Has to be the kind of person you've gone bass fishing with for 40 years. To make it more and more expanded, to now it's like acquaintances, somebody who they kind of like based on a website, but they haven't met in person. And when in Denver, when there was the first case through this matchdonors.com, and they actually did a kidney transplant from somebody who had met off the web, there was a big backlash in the transplant community from this, and people said, this is not something we should do. But, that lasted about 6 months. And now it's starting to be done at a few places. Now we're up to about a dozen places. And we just see this keep increasing. And the more we move to that system, the more inequalities in access are going to be exacerbated, the more that bias in distribution is going to be increased. It's outside of a relatively fair distribution system that we've got within UNOS. It increases the likelihood of illegal payments, and you can't help noticing that the first patient in the case in Denver, was somebody who turned out was a recently released convicted felon who was also a deadbeat dad who was wanted, and as a result of the publicity got arrested. It increases many of the problematic aspects of live donation in terms of risks but no benefits. And there's also just practically a difficult challenge in terms of psychosocial assessment. There's only a few programs in the country that allow non-directed altruistic donation, people who can come forward and say, I'm going to donate a kidney to whoever's next on the list. Those programs do very rigorous screening because they're set up to do them, and they exclude the majority of the people who come forward. Right? It puts a lot of burden on those programs to do that adequate screening. Most programs don't have the resources to do that kind of screening, and I'm nervous about what happens if you don't have that much screening. We've already had a few people come forward to our ethics committee who've requested to be allowed to have a directed donation for them through the same website, and some of them who came forward were very honest about saying about half of the people who responded wanted money for their organs, and we don't have the mechanisms to really, we don't have the ability to make sure that that's not what's going on in these kinds of cases. It puts too much pressure on our system. The desperation for organs that's leading to these kinds of solicitations is now producing a growing industry in transplant tourism. China finally publicly admitted in a big step that they actually use organs from prisoners. Although the majority of those prisoners are criminals, they also do include political prisoners. And so these are organs taken from prisoners who are executed against their wishes. And essentially we've got an international market in organs from not just China, but from a number of countries. And then when they come back, we often have to manage those patients, or if the organ fails, then list them for a new one. And they may actually, if somebody goes to China to get a liver and it fails, they may jump way up to the top of the list because of its failure. And this, in a way, makes all of us complicit in this tourism. And I think that's actually a real problem. We obviously have an obligation to take care of these patients, and we're going to continue to take care of them. But I wonder where the shame is. What amazes me is how many of the patients who are doing this and going to China and essentially buying these organs are proudly proclaiming it and feel absolutely no sense of shame. And that's partly because we haven't done anything to really say that this is really bad. And we need to do a much better job of making it clear that we find this morally reprehensible. And I think if their clinicians did that, I think that would help. People should be embarrassed about doing it, not pleased and proud that they were able to go and get an organ and at a cheaper price than they would have in the U.S. So recommendations, should no longer allow listing with multiple OPOs. Several people have called for this. Restrictions must be placed on directed donations. Only exceptions to fair distribution of organs should really be for loved ones, people who you're close to in some respects. Communication of standards should be done at time of assessment. That's the most important thing for solicitation, is that when people come in for their initial assessment for listing, it needs to be communicated to them that solicitation is inappropriate, that transplant tourism is appropriate, and that these are condemned by the programs at the beginning to optimize the probability that it'll have an impact on behavior. Let me now turn to donation after cardiac death. Donation after cardiac death, as probably most of you know, is a situation that arises when patients are not brain dead. But instead, the patients are alive, typically on ventilator support, and a decision has been made to withdraw life support, and there's a corresponding clinical judgment that the patient will have their heart stop within an hour or two. A lot of the policies say 2 hours, but in practice it's 1 hour usually. After an hour, the surgical teams are going to leave. You typically provide some preservative efforts prior to withdrawal, but not extensive. And then basically what you do is you bring the patient into the operating room, withdraw support, and then after the patient's dead, retrieve the organs. One of the big issues in this process is asking the question, when is the patient dead? And that's an interesting thing. We have very clear criteria for brain death. We do not have clear criteria for cardiac death, right? So if a patient is full code and then winds up their heart stops, and again this is a non-brain dead patient. If it's full code, how long is the patient still alive? Well, when do you give up on the resuscitation efforts? 5 minutes? 10 minutes? 15 minutes? Right? It's indeterminate. It's a clinical judgment. But it's probably more than 5 minutes for a large percentage of the cases. So then what about somebody who's in a DCD case where you're going to try and procure a non-heart beating donor? Should we see that as patients being alive for that same length of time? But look, in contrast, if this is a no-code patient, so there's a DNAR order, and this happens in the ICU, and the patient's heart stops, how long before you declare a patient dead? So a patient who's no code and their heart stops, how long before you declare them dead? 30 seconds? Something pretty quick, right? So maybe they're dead 30 seconds. Maybe we should see these patients then as being dead 30 seconds in. A lot depends on what it means when you talk about irreversible cessation of cardiac function. Does it mean circulation can't return regardless of any possible interventions? That might be a long time. Does it mean circulation absolutely cannot return, given that interventions will not be attempted? Or does it mean circulation is unlikely to return, given that interventions will not be attempted? Right? So in the ICU, we use this third one. In the if it's a no-code patient, and this one if it's a full-code patient. So I think this middle one is probably closer to where we ought to be aiming at for DCDs. And the bottom line is there's no bright line. And that the intentions really do matter. The decision to make a patient no code really makes a difference. For adults, there's pretty good data that after 2 minutes, there's no chance of spontaneous return of circulation. And so 2 minutes out seems like a reasonable time to say that a patient is declare a patient dead. 2 to 5 minutes seems like it's all justifiable. The IOM report recommends 5 minutes, and that seems to be what's becoming the standard norm. But if you read the IOM report, they say the evidence shows 2 minutes out is safe, so let's make it 5 minutes to be safe. And it's sort of just this arbitrary number. One other caveat, we need better data for pediatric cases. Every time you have a pediatric get-together, there's a group that talks about pediatric cases where kids have spontaneously had resuscitation 7 minutes out, 9 minutes out. So lots and lots of stories. We need that if we're going to be procuring organs from this population. We need better PEDS data. Some of the worries that people have, aside from whether the patients are really dead, which I think can be answered, is the conflict of interest problem. And there are two different conflicts of interest that go in two different ways. One worry is what happens if you've got a physician who's taking care of a patient who's a likely recipient of the organs. At the same time, they're also taking care of the patient who you're deciding to withdraw life support and whom you might procure the organs from. Right? That's an obvious conflict of interest. Will you push a little to withdraw a little sooner or under those circumstances? That's especially a problem in pediatric hospitals where it's more likely that the teams are going to be taking care of both patients. There's also the opposite concern. We've all had those cases where you get brought in, where the ethics committee gets brought in, and the physicians are all working very hard because there's been a terrible accident. You've got a young person who's now in a persistent vegetative state. Nobody believes that keeping them alive like that is really in their best interest. Nobody believes that that's really what the patient would want. But the family, although they say that that isn't what they would want, they won't agree to withdrawal of support because they just won't accept the prognosis. Right? And we work really hard. Is this because of insurance? Is this because of this? Why are you saying these terrible things? We've all had those difficult cases where it takes a lot of work to finally get the family to accept the prognosis, come to terms with it, and agree to go to comfort care and allow the patient to pass away. In those kinds of cases, bringing up organ donation may reopen that issue and may very well lead to backtracking on the decision to withdraw for those patients and therefore undermine the patient's best interest, which in this case is served by going to comfort care. So both of those are, I think, conflicts of interest that we have to worry about, and there are similar institutional conflicts of interest about whether we should set policies to make it easier to withdraw on patients, as well as the fact that we administer heparin, which is not necessarily in the best interest of the patient, but in the best interest of the organs and future recipients. So there are definitely conflicts of interest that we have to worry about. But I should say a word, which is conflicts of interest don't mean bad. They mean they need to be managed. And so I don't think this means DCD is a bad thing. It means that we have to be thoughtful in the policies that we set. Another set of concerns is worries about trust. We know that a smaller percentage of people are willing to be DC donors than brain dead donors. You can see in media stories there's anxiety about this. And I think we have to worry about the loss of trust. But I will just counter that by saying if patients want to be organ donors, telling them no could just as well be a problem for trust between patients and physicians. So I think that one cuts both ways. There's also informed consent issues. In situ administration of preservative agents, which are not, again, in the patient's best interest but the organ's best interest, would seem to be something that ought to be told to the people who are going to be the donors, and there are some states that require it, but there are a lot of states that actually do not require that as part of the consent process. Also critically important, given that we're not very good at predicting when somebody's going to die, is the fact that there's a good chance that when this happens, you're going to wait around for an hour, and then they're not dead, and now what? Now you're going to send them back to the hospital from the OR when you've been gearing everything up for this. And so it's really important that the family understands what's going to happen to patients under these circumstances, as well as making sure that you have antecedent consent for withdrawal and comfort measures before the decision to be a donor, and that you provide information on how complex this process really is. There's also euthanasia anxieties that we've definitely seen from some hospitals. The heparin may lead to death. The comfort measures for the patient could lead to death for patients. And if it's a patient who can't experience pain because of the amount of brain damage, you could argue that the doctrine of double effect, which is how we usually justify providing treatments that have a foreseeable but unintended consequence that they may hasten the patient's death, it's hard to see how you can quite make the same double effect arguments. Nonetheless, I think even in these cases, if you've got consent and it's something that would be important for the patient to do to be an organ donor, I think this could be justified. So here are some recommendations about DCD. We need to separate roles. So the decision to withdraw has to be prior to a discussion of donation after cardiac death. We need adequate oversight. We at Stanford require an ethics committee review of all donation after cardiac death cases. It's really important that attendings play a very active role to make sure that they agree that it's appropriate for conversation with the family about donations to take place, and that it's in their best and not a violation of the patient's best interest prior to actual discussion. The discussion of DCD should be done by someone other than the treating team. Those who determine the time of death should not be the transplant team, and withdrawal should be as much like any other withdrawal as possible. Our goal is as much as possible to make the withdrawal of these patients just like any other withdrawal, except that a few minutes after the patient has been declared dead, their organs are procured. Include all the key elements in the informed consent process, and that should be documented. Patients who have capacity who want to donate, we require psych evaluation. Hard to imagine this ever happening, but I was at a transplant meeting where this has already arisen, where somebody who actually had capacity and was vent dependent was able to say, I want to withdraw, and I also want to be an organ donor. Obviously, in that kind of a case, you'd want a psych evaluation. I think you're dead 2 to 5 minutes after cessation of cardiac function, though for pediatric cases, we should collect more data. Let me wrap up by turning to the scandals in California. In St. Vincent's, the problem was that there was a liver offered to a Saudi Arabian patient who was unavailable. He was out of the country and couldn't get there within 24 or 48 hours. And instead of refusing the organ and allowing it to go into the next patient on the list who was at UCLA, they decided to go ahead and transplant it into another gentleman from Saudi Arabia who was on their wait list, even though that patient was actually 52nd on the wait list and actually 9th on their own internal list. They initially gave the information to UNOS saying, this is who we transplanted, and then after that, they basically said, no, that was a clerical error, and then lied to UNOS about who was transplanted, claiming that it was the patient who did not receive the organ, who was then taken off the list, while the person who had gotten the liver was left on the list. The patient who was at the top of the list was told that he was stable and no need to return, and subsequently died. So that's bad. So you have my professional opinion. That was bad. UC Irvine liver program. Between 2002 and 2004, they were only performing 8 transplants per year, which is lower than the minimal number required. In late 2004, they lost their last surgeon who was on staff, who even before that was mostly doing other kinds of surgeries, and they were told basically that their program was going to be shut down. So at that point, they lied to regulators, claiming that a surgeon was moving from UC San Diego to UC Irvine. That surgeon had agreed to help cover at Irvine, but had no intention of going there. And so they continued the program without a full-time surgeon, using these other people when they were available, meaning that there were many periods where they simply had no surgeon available if an organ should become available. And so that results were that many patients had organs turned away, and their survival rates were unsurprisingly below required levels. In 2005, they performed only 5 transplants. The number declined that bad. But again, during this time, they have this full list of patients. So the number of transplants being performed is declining because they don't have the resources to do it, but their list hasn't gotten smaller. Periods where there was no transplant surgeon in the vicinity, they wound up turning down a large number of matched livers, 3 times the rate of other programs, and 32 patients died on the waiting list. And the patients were not informed of the lack of a surgeon or changes made to their status, and it's clear that there was inadequate resources to manage the patient population. This story in some ways is similar to the Kaiser kidney program problem. Kaiser decided that they were going to move their large number of patients who were being managed at UCSF and UC Davis in-house. And this was over 1,500 patients who were on the list who were going to be moved all at once to a brand new program. The 2 years prior to this change, 168 Kaiser patients received transplant each of the previous 2 years, combined at UC San Francisco and at UC Davis. Once they made the transition, a year later, even though the list grew, only 56 patients received transplant. And as this happened, they kept accepting a lower and lower percentage of kidneys. It was clear that it was poor planning and implementation of the transition, which resulted in harm to the patients during the transition. There was inadequate resources for managing the population. They didn't have enough nephrologists. They didn't have enough surgeons. If you look at the number of surgeons they had, the number of nephrologists they had enough to manage about 56 patients, which is how many they then transplanted. But that population was having 168 transplants done for them before this transition. They had insufficiently trained nursing staff, insufficiently trained clerks for dealing with paperwork in the UNOS computer system. There are a lot of other problems with Kaiser that I could go on and on about, but I think these 3 cases lead to some important lessons, especially the last 2 cases. We need to have minimal standards for the number and training of non-physician staff members, including those responsible for mandatory paperwork. And we also need to require minimal standards for the number of surgeons and nephrologists needed relative to the size of the patient population. Right now, the way the standards work is you have to have a surgeon, and you have to have a transplant nephrologist. But there's not a requirement that says if you've got this big a patient population, you have to have this many surgeons. You either meet the minimum requirements or you don't. But it doesn't ratchet up the requirements. So all Irvine needed to do to solve their problem was have somebody who counted as a surgeon available full-time doing at least 12 transplants a year. But then they could have as many patients in the population as they want. They'll just turn away more organs. But that creates a huge problem for patients, especially who have no idea that this is happening to them. So we need to have better standards in this regard. And it's going to be very complicated to put this data together. We started working on trying to figure out some ways of making some kind of rough assessment. But I think if there's any area where we can put this data together, it's this area. And then we also need to require, in the Kaiser case in particular, this was a problem, internal oversight of programs from upper management levels within the institution is going to be critical. And we've already seen now what can happen when you don't have that taking place. That's it. So thank you very much. Covered a lot of ground. So I know there was a question earlier back of the room. So the question is, how do you get listed with multiple OPOs if you have money? Basically, you can go to if you've got the money that allows you to go to different transplant centers in different parts of the country, and you can guarantee that you can be there within 24 hours, you can rent an apartment, do whatever it takes to do that, then you can go around the country and, yes, list yourself in multiple OPOs around the country. And there are individuals who do that. There are some individuals who just move to have the resources, there's some places in Florida that have the lowest wait times, who just say, I'm going to just move for 6 months to Florida or a year to Florida and be on that wait time so I don't have to wait. Others, if you don't have those resources to be able to guarantee that you can get there in 24 hours or to have an apartment there, then you can't do that. And also some insurance carriers really essentially mandate and limit how your coverage works, so you essentially are de facto required to only be listed within the one OPO and be treated by just the one transplant center within one OPO.
I take it that the list of persons who are in need of organs does not include people who simply cannot afford it and thus are not on the list.
Correct. Which is presumably a much larger number of people who potentially could use organs who don't get listed. That's correct. So the people on the list, these are all people who actually have gone through and they've done the assessment and said yes, and they've been put on the list. And it's a funneling.
I have a friend who's on that non-list.
Right. Well, there are a lot of people who, for financial reasons, for medical reasons, for psychosocial reasons, and it is hard. I mean, I've been called in on a number of cases where either the primary care physician or psychiatry or some other physicians were unhappy about a patient who was not, a decision was made not to list them. And usually in those cases, you can understand the argument for why there might be an adherence problem, and so it's not an unreasonable decision. But it's really hard, and you do notice that there are certain patients who it's a lot harder to get them listed. If you're a poor person from the Central Valley of California who doesn't speak English, it can be harder to get those patients listed than a patient who suffers acute immediate failure as a result of ingesting bad mushrooms on a mushroom excursion who's from a wealthy area in Palo Alto. And so that's, again, another inequality in the system.
I'm the medical director of the OPO here in Kentucky, so we deal with these issues quite often because our waiting list is, for kidneys is less than the average waiting list is less than. When you do,
So here's where you move to from the Bay Area. If you've got the resources, you move to Louisville.
That's for kidneys. We have no patient that dies for one of the liver here in Kentucky.
Yeah, it's certainly not true where we are.
Yeah, that is true. It is my estimation that what drives this is the effectiveness of the organ procurement agency. And it meets your patient population. Those San Francisco, New York, that have those long waiting times also have the poorest performing OPOs. And so it's a matter of the organ procurement agency having enough staff and enough effort and enough shoe leather to be out there pushing the concept to society of organ donation.
Yeah, I don't think that completely explains it because, I mean, you do notice that there are demographic differences that are associated.
But that is a factor. When you talk about the multiple waiting list, you can be listed on multiple programs, that's for sure. But in kidneys, where the issue of waiting time is a factor, does not transfer. So if we had a person who's been on the waiting list from California that came to Kentucky after 3 years, they could transfer their 3 years of waiting to Kentucky list, but they would go back to the OPO in California as 0 time on the waiting list. So there is some equity as it relates to kidney waiting time in that factor. On livers and hearts and lungs, it's not quite as well regulated. I have one sort of question. Where, and I relate back to your pediatric disabled child scenario, and as a physician who has to make those decisions, where is the physician's obligation to society? In other words, that organ is not going to waste. It may not be going to this child who is severely mentally retarded, but if it goes to that child, there's another child that basically could be a very productive participant in society. And so where is the responsibility from an ethical point of view from
So the question,
society as a whole? Because the government is paying for us.
Right.
Society is paying for us.
So the question is, how do we deal with the obligation that physicians have to society for organs and the issue of cognitively impaired kids, especially given that those organs are not going to waste. When you decide not to list one of those kids, there's somebody else who's getting those organs. I mentioned before that one of the things that makes organ transplantation different than other allocation issues is there's always a concrete other person who's harmed. That means when you list a cognitively impaired person and they wind up getting that organ, there's another healthy person who's not getting it. For kids, it's a little bit better than for adults, so kids are preferentially treated. So for at least for kidneys and for livers, it's a little bit better. For very young children, though, for hearts, it can be a problem, particularly a problem. So you're making a decision about, I've got this cognitively impaired child. Do I give a heart to this child versus a healthy, fully functional child? I tried to capture that with that notion of stewardship. This notion that there's an obligation to be a steward of this scarce resource. And I don't want to say that that's not a powerful part of this, but at the same time, there's also justice. I mean, where do you draw the line? And you could say, well, sure, but you know what? This kid who's got an 100 IQ and has C+ grade average, and then there's this other kid who's an A+ student. Maybe we should list the A+ student over the kid with only 100 IQ. So where do you draw the line between this really smart kid, the average kid, a kid who's mildly impaired, a kid who's mildly retarded, a kid who's moderately retarded, severely, profoundly delayed. And where do you draw that line? Everybody, so how do you weigh? So it's really interesting to me because it really is a trade-off between justice and stewardship. And we don't have consensus about where to draw that line. We all agree that giving it to a patient in a persistent vegetative state is wrong. We all agree that mildly impaired kids, that's not sufficient grounds to not give it to them. Although they are, in fact, not given them, as both the Levinson-Olbrich data and our data shows, those kids are being excluded. That seems wrong, and there was pretty strong consensus that that's wrong. In between, we did not have consensus, and I can tell you there was bitter division between different ethicists, different transplant folks. For me, we gave a couple of examples. We had a liver patient who we were the third or fourth transplant center that this person had come to, and this was a 10-year-old child with a mental age of well under 6 months of age, who basically, he was not in a vegetative state. He scratched because he was having really bad pruritus secondary to his liver problems, but he had a whole range of different medical complications and medical problems, and there just was a sense that there was no there. He could interact in some way with his environment because he could itch, but he couldn't. The developmental assessment showed complete unresponsiveness to interacting with anybody, and we just thought giving a liver to this kid was not justifiable. And I feel justified in that decision, and I felt like that was the right call. In this lack of consensus, I was in favor of drawing the line higher than PVS. Legally, not clear if you can do that, but I think ethically you could justify drawing the line higher than that. But there were other people who felt just as strongly that anything over a PVS, it's a benefit to that patient, and we don't have a right to make distinctions between these different patients. And so we were not able to get consensus. Everyone agrees at the extremes of PVS and at higher levels of functioning. Lower levels of functioning, there's not consensus. That's why I think the process in the end will matter more than anything else. By having a good developmental assessment with a real good pro as part of the team, she's able to really bring out the difference between that patient and another girl who we did wind up listing for a kidney and has received a kidney, who, while severely and maybe even profoundly developmentally delayed, there's a there. She's nonverbal, but she interacts. You can play games with her. There are things you can do. There's clearly a strong sense of benefit on the part of her family for this patient, and everybody can see it. And they agreed to take care of her on dialysis and had established that they could do so. And there's a difference between those two cases, even though IQ is just a marker. Anyway, but where you draw those boundaries is, I think, very, very tough, and we don't have consensus about that, either within ethics or within transplant programs.
Let me follow up on that then, to suggest that one of the reasons that I suspect this is a problem is that at least some people are attempting to maintain the unmaintainable, that we must treat everyone equally, regardless of status, even in situations where we have severely limited resources. And the fact of the matter is, it would be nice to be able to do that. It would be good to be able to have enough resources to do that, but we don't. So if we try to stick to the claim that we must treat everyone equally, you end up with a situation where people were saying, well, this is of benefit to this patient, therefore we have to treat this patient equally with someone else, which, as you pointed out, leads to people in the decisions of who gets listed and so on making essentially ad hoc decisions as to whether or not we're even going to bother listing person X, Y, or Z. If we're going, and therefore we're not making judgments that everyone is equal, we're making judgments that everybody's not equal. And I think we absolutely have to embrace the recognition that that's what's happening, whether it's ad hoc or not, and do it, because we're already doing it.
Well, I guess I would want to distinguish a couple of things. So everybody doesn't have an equal right to an organ, because to some extent that's going to be random depending on circumstances. But the right to be listed, the right to get an opportunity to get one, is something that not everybody has a right to either. But you have to make sure that if you make the distinction and say that somebody's not entitled to it, that there's a reason. We should treat likes equally, and people who are unlike. We're justified in treating people who are different in a relevant respect differently. And so the question is cognitive status, developmental delay. So if you've got adherence problems and could establish that, that's genuine cause. If you can establish, but if you don't have that, how are you going to establish that simply cognitive status is grounds for distinguishing in these kinds of cases without making other invidious distinctions and drawing the line and saying, since it's a limited resource, why don't we give it to the smartest kids? Why don't we say, this is a kid who's from an affluent family, this is a kid who's much more likely to go to college and be a productive member of society than this lower middle class family. We should preferentially give preference to them. But we don't do that, and we think that that's not fair and not right because the relevant differences between them are not relevant for adequate health care, which is should be based solely on whether or not they can benefit from them. And so I think in the end the issue really is there enough benefit so that the benefit burden ratio of being a transplant recipient makes it appropriate within the scope of being a good steward of the resource. For my own self, I would draw that line significantly higher than PVS, but I think that's where the question is.
But you've asked a rhetorical question. Why don't we do it this way? And that needs to be answered. No, we don't, and we shouldn't. But by answering that question, we will actually come up with the criteria that we can use then to tell us where we ought to be drawing that line.
So the fact that we weren't able to reach consensus, even among a group of ethicists, is a sign that we're never going to solve this problem by drawing a line. I mean, we can draw some lines and say these kids ought to always get it and these kids ought not to, the PVS kids. But in the end, I think the process is what's going to matter. And I actually really mean that. So I don't think that's just because we happen to fall back on it. I think that for the liver program, the person who did the developmental assessment, and most liver programs don't have anybody who's really a professional doing it in the same way, it makes those kids come to life as part of the listing scheme. So they really have a sense of that child and who they are as part of the listing process. And it profoundly changed the culture of our liver team. Our kidney team, which was grappling with that case I described with the kid who there was clearly a there, though she was nonverbal, when they had the liver team's person do the developmental assessment for them, their initial inclination not to list that child was completely turned around by their complete understanding of making alive to them who that child was. And that said to them, we need to have somebody like this for our team. I'm convinced that if we had somebody like that as part of our heart team, the culture of our heart team would fundamentally change. So I think having the right processes and having the right people involved in actually could make a big difference so that kids who right now are being excluded unethically for no good reason would get listed. And that's really the thing that I think I'm most worried about, is not that there are kids getting organs who shouldn't, although that may happen sometimes, but more frequently that there are kids who really should be getting listed who are not. And this, I think, would go a long way towards solving that problem.
I just want to ask, to me at least, a simpler question. You talked about the 95,000 that were on the list, but made the point that because of finances, many other people aren't listed. Isn't that an even more basic question, that finance matters whether you get on the list?
I absolutely think that does. I also want to make it clear that I think we do a lot of states and a lot of areas do a pretty good job of getting people enough coverage to get onto those lists. So I think it's easy to overestimate how important the wallet biopsy is for this process. But there are exceptions, and in some ways, what's hard is, we don't have a single payer system. We don't have a rational system. So the state of California has decided we'll pay for that, and then we have to live with the consequences of $1 million procedure. The state of Nevada looked at it and decided that's not something that they thought was worthwhile to cover. So that's a decision that they've made, and there are state boundary issues. If we decide as a society, if we go to a single payer system and decide as a society, here's heart transplants are worth it under these circumstances and not these, then that's what we'll deal with. Hypoplastic left hearts, it's better to do surgery than transplants or something like that's something that we just would have to decide as a collectively. At the bedside, though, is the wrong place for us to make those kinds of decisions.
When I was on the ethics committee at the University of Pennsylvania, we received a letter. The letter was from a gentleman, this was now 5 years ago. It was from a gentleman who said, I want to go ahead and donate one of my kidneys. I don't know who I want to donate it to, I just want to help humanity.
Right.
And I would like to go ahead and donate one of my kidneys. And we looked at this letter and we were quite befuddled by that, saying, this is an interesting act of altruism, but does he really have all his oars in the water? And we had some questions for the organ transplant program as to whether indeed this person needs to be evaluated for that, but that if indeed he had that altruistic desire, that he may wish to pursue it. However, at that time, the organ transplant program said, what, are you crazy?
That was with Europe. Yeah, there are 3 programs that do that.
Well, that was the thing. So what happened was about a year and a half ago, there was a Philadelphia Inquirer story that got forwarded to me about a gentleman who went ahead and said, I want to go ahead and give a kidney. And he went ahead and he gave a kidney to this patient from West Philadelphia who needed a kidney, and how he felt great joy knowing that it was useful for somebody else, and she felt great joy and that her life had now a possibility of being extended.
Right.
So, and it sure sounded like from the story he told, it was the same person. So I'd like your position on the whole notion of altruistic, non-directive live donation.
Well, at a minimum, it requires a lot of very careful scrutiny and management, and the small number of programs that do that, as I mentioned, exclude most of the patients who come to them. And I think it's not fair to expect that every transplant program in the country should have the same kind of resources and screening set up that those programs have. So I think it's not unreasonable for programs to say, we don't do that. We don't have the resources to really do that level of screening for this kind of patient, and we're not going to take care of that. I think that's not unreasonable for a program to do. That's fine for there to be other programs that do. Now, even for those other programs that do it, there's still this question that is troubling, that these people who are coming forward and donating are harmed for no benefit to them. And there's, significant morbidity, 1 in 2,000 chance of death, something like that. So, and the question again is, where do you draw the line? Kidneys, what if they want to donate a liver lobe? That's much more risky. So would you let them do that? To what extent do we just say this is a libertarian approach? If they want to do it, we also let people ski and jump out of airplanes and bungee jump and do all kinds of crazy, foolish things. And I do some of those. I ski. I do some of those foolish things. So maybe this should be seen as like that. So I'm not sure where I come down on that. But at a minimum, I think it should be up to programs to decide whether they want to do it and to make sure they have adequate screening in place if they're going to do it. And it's okay for programs to say, we just don't have the resources to do that. I think that should be allowed. And they can refer them to the programs that do have those resources. There's lots of things that we don't provide. Right. So I think that's appropriate.
Any other questions? Yes.
Yeah. First, I want to say thank you for today's information given us. But I think you do the biomedical ethics. You are the very important people. But I think after I hear you say about the donor for the organ donation, organ transplantation, depend the kids' IQ. I totally agree. This is just the moment someone talk about it. Because first, human is equal. Everyone is equal. Is right. Everyone is human right is equal. So also if you depend the kids' IQ how high they do it, this will come very wrong. Because especially for children, when they're young, you don't know the kids, if they treat them very well, how in future
right.
can growing good. Because I had one friend, they had one the children, is premature, 27 weeks due, they get the brain bleeding is grade 4 and grade 3. After the both, her daddy, the supervisor, is very famous American pediatrician doctor. They said
right.
needed quickly termination.
So,
but they didn't do termination.
Right.
Because they said maybe the kid in future is
right.
cannot speak
right.
anything, not good.
So
I think because I want to say this, I cannot do anything. But I think for your sales person, need to think about this. For parents, every kid is equal. Doesn't matter if it's disabled or mentally disabled, physically, everyone is equal. You cannot choose this for you when to choose. At least I think in the waiting list for it's okay. But if you depend this kind of, I think for me, I think it's very not
right.
good.
So
I hope I know this field is very complicated, but I hope you are working on this field can do much better job. This is my
right. So the question is, one of the problems and complications with pediatric assessments of developmental delay and projections is how hard it is, especially we're often doing it with very young kids and trying to figure out how they're going to develop and what's going to happen with them. Absolutely, that's again highlights why the process matters. If you have a good developmental assessment person and specialist, she can help with that and point out, we don't know, and that sometimes happens. We had another case with our kidney team where they thought, well, we don't think this kid's going to really develop very well, and our developmental assessment person said, no, actually the kid's starting to perk up. The brain looks terrible, but the kid's looking better a year later than they did earlier. And so I think having that developmental assessment is important. But where you draw that line, I think everybody agrees that a persistent vegetative state, some cognitive status has to be relevant, because a patient in a persistent vegetative state, we can't possibly justify wasting an organ on somebody who's in a persistent vegetative state.
If you decision make people don't thinking about this kid is disabled or some mental IQ low, if you thinking they can always can found something, let the kids calm down or something, don't squat, there's so many medications can treatment.
Well,
Prevention the kids do some bad things.
For some things, yes, but for some things, no. So.
That's my feeling. I just thought that everyone's okay.
One other, just we talk about the pediatric. How about the other end of the spectrum? A fellow who's 75 years of age and gets on the kidney or liver list.
Yep.
Of course, as you're aware, in the United Kingdom, have an age limit.
Yep.
Over 60 is where you don't get kidney.
Yep.
Regardless.
And actually, there's some places within the U.S. where that's starting to become a criteria as well. And I know that's raised an issue. Yeah, graft survivals, I mean, you could argue that some of those cases are based on objective biological criteria about prospects of graft survival. But you're right, given the limited resource, how do you do that? We do differentially give preference to pediatric patients in general in the allocation system. Could we extend that? People in their 20s and 30s should get preferential treatment over patients in their 70s. I mean, I think those are really tough questions. We have not addressed that issue in our group, but I think that's a really interesting area that should get looked at.
Repeat the question. Yes, go ahead.
My question is related to living. I'm transplant surgeon. For living kidney donors, how much of risk are we willing to subject our donors to? As you said, that's there are two extremes. One which are very clear cut, who are old, or more than 60, who have diabetes, hypertension. Those are very easy to decide. But with obesity increasing in the U.S. population, a lot of obese people want to be donors who are young. And we know that when BMI exceeds a lot of, especially 35, a lot of these individuals are going to develop type 2 diabetes 5-10 years time. Now, right now they look healthy, and it's technically possible to remove those kidneys and put it in. But what should I think? What should I think? Is it am I justified in accepting these people as donors?
That is a fantastic question. So if you've got patients who right now are technically meet the criteria to be eligible for be live donors, but where the risks long-term, given their body weight, means that they're going to be at significant, not just the background rates from what we understand the risks of being a kidney donor, but maybe substantially more than that in the future, where do we draw the line and say it's too risky to do that? I think that's a very interesting question. It's a trade-off between a couple of different things. For a patient like that who is going to do an altruistic donation, I think I would be very loath. At a certain point, I think the threshold of risk, it makes sense at a certain point to become paternalistic and say it's just not appropriate to take on this degree of risk for no benefit as much as you might want to. But it would be different if it's somebody who you're making a direct donation, I think, to a family member. I mean, let's face it. If I could, if my wife needed a heart, if somebody would let me, I would donate my heart for my wife. And so I think obviously we can't go that far, but you might reasonably say that people can take on greater risks for people who they're very, very close to, so it may not be the same in all cases, depending on whether it's for their loved ones or whether or not it's for a stranger or somebody who they're very distantly related. But I think that's and obviously critical to this is going to be adequate informed consent and making sure that they really understand the risks and want to go forward with it. But I think that's really how I would think about it. Is it depends on the circumstances, because then it's really about benefits versus burdens, where the benefit is not medical but it's social, and you have to decide essentially that the benefits to that person and that family and that situation outweigh the burdens that are increased for that patient. If the benefit-burden ratio doesn't work out, which it probably would not for donating to a stranger, then it's probably not worthwhile. But if they're close enough, that benefit-burden ratio might be justified even with a higher risk level. But again, it doesn't go indefinitely.